Assalamu alaikum wa rahmatullah. This lecture is about brucellosis and enteric fever. To get the most benefit of this lecture, please goals mentioned. Other names for brucellosis: indolent fever, Mediterranean fever, Malta fever. It is endemic in animals, caused by gram-negative coccobacilli or short bacilli. As we know, it is transmitted via the contaminated or untreated milk and milk derivatives, or direct contact with infected animals or their carcasses and offal, يعني فضلات. There are 5 species of brucella. Number 1, which causes the most severe disease, is Brucella militensis, usually associated with goats, sheep, and camels. And number 2, Brucella abortus, which is associated with cattle. Number 3, Brucella suis, swine brucellosis, often associated with abscess formation. We will come to that later. Then number 4, Brucella canis, which is associated with dogs, which causes mild disease. Lastly, Brucella ovis, again associated with sheep. No evidence of this species that it can cause a disease to human. Brucellosis is a very rare disease in developed countries because they have eliminated the brucella from their animals by vaccination, pasteurization, screen and slaughtering of the infected herds. But still it's endemic in many other parts of the world, including our country. Brucellosis again should be considered as occupational disease. Affected laboratory workers, vets, and slaughterhouse workers. يعني اللي يشتغلون بالمختبر، أطباء البيطريين والقصابين. If you face a patient and you think about brucellosis as a potential diagnosis for his fever, for example, please ask about travel history, his diet, if he's taking untreated milk, unpasteurized dairy products, and possible exposure to the animals itself. Please note that ingesting contaminated dairy product is not the only way to get the infection. We can get infected through abraded skin, or by inhalation, or through conjunctiva if we have exposed to the animal excreta. Human-to-human transmission has been documented, but it is rare. After entry to our body, the bacteria live in the regional lymph node during the incubation period, which is usually 2 to 8 weeks, then enter the circulation when granulomatous lesions will be formed in different parts of reticuloendothelial system. Remaining organisms within granulomas are responsible for the relapses of acute disease or result in chronic brucellosis. I would like to simplify the clinical features. Fever with its wave-like pattern, sweating, which is profuse, malodorous night sweating, joint pain and bone pain, testicular pain. Other non-specific features include headache, depression, weakness, and myalgia. On examination, hepatomegaly, splenomegaly, along with lymphadenopathy. Other sequelae are summarized in the next slide with the figure. This slide summarizes all the clinical features associated with the brucellosis. Blood and bone marrow culture are the definitive diagnosis method. We have to warn the lab workers about requesting brucella culture because it needs an appropriate biosafety level. Of course, bone marrow is not routine to be requested, but it increases the yield of a diagnosis if antibiotic previously given. CSF culture is important in neurobrucellosis. Lastly, about serology, which needs a single high antibody titer of more than 1 over 320 or a four-fold rise in titer need to support the diagnosis of acute infection, although it needs several weeks to become positive, like mentioned, but it will eventually detect 95% of acute infections. Regarding management, we have to note that we need an antibiotic that enters the macrophage and works in acidic environment. The routine combination is doxycycline plus streptomycin or rifampicin. Fluoroquinolones have a role in relapsed or resistant disease. Some infections, as mentioned, need triple antibiotic and more prolonged period of treatment. Others with sepsis, for example, or endocarditis may need surgery. We can use antibody level to measure response of our disease, need pasteurization of milk, other standard of hygiene. Eradication of disease need testing all animals and slaughtering those with positive results. Now with the second part of our lecture, typhoid and paratyphoid fever. This disease is also endemic in many developing countries, transmitted by the fecal-oral route, and there are two species, Salmonella enterica serotype typhi, Salmonella enterica serotype paratyphi, which again have A, B, and C types. Please note that the Salmonella food poisoning, which causes diarrhea and sometimes even bloody diarrhea, is different from these serotypes. The degree of food contamination with this bacteria and the gastric acidity are important determinants of disease severity. Means if anybody is taking proton pump inhibitors are more prone to get the disease. Again, this pathogen has the ability to survive within macrophage, and this will explain many of the symptoms and signs of the disease. As after a few days of bacteremia, the bacilli localize mainly in the lymphoid tissue of the small intestine, resulting in typical lesions in the Peyer's patches and the follicles, which first swell, then ulcerate, and usually heal. The organism re-enters the bloodstream after multiplying in the Peyer's patches, then re-invade the small bowel, causing bleeding and peritonitis. The Salmonella typhi has the V antigens, which gives him a good defense mechanism against our immunity, so that 5% of patients become chronic carriers, and they continue to excrete the bacteria after 1 year. Gallbladder will be the main reservoir of the bacteria of this bacilli and will live there for months or years, and then pass intermittently in the stool, but less commonly in urine. Regarding the clinical features, we will talk firstly about typhoid fever and then about the paratyphoid fever. The incubation period of typhoid fever ranges from 5 to 21 days, and that's depend on the inoculum size, age, gastric acidity, and host immune status. And the onset will be either acute or insidious. Abdominal symptoms will initially develop, then followed by non-specific symptoms. After that, fever will develop. Fever has a specific step-ladder pattern for the first few days, associated with headache, drowsiness, malaise, and ache in the limbs. To mention is the mechanism of constipation is associated with the swelling of lymphoid tissue around the ileocecal junction. We have to notice that in children, diarrhea and vomiting may be more prominent. We all know that heart rate will increase in response to increasing temperature, but in typhoid fever, this response is not linear, so there will be what we call it a relative bradycardia. This table from your textbook summarizes the features of typhoid fever. The main three categories of clinical symptoms, which are the abdominal symptoms and the non-specific symptoms, then fever, these all three are sequenced in the first week. And by the end of this week, a rash may appear on the upper abdomen and the back. And to mention, cough and epistaxis may occur. Then, during the second week, the spleen will be palpable. The abdominal symptoms will progress to diarrhea, abdominal distension with tenderness, sometimes bronchitis and delirium. And by the end of the second week, the patient may be profoundly ill if untreated. Now regarding the paratyphoid fever, which tend to be shorter and milder with more abrupt onset. And please note that the rash may be more abundant and the intestinal complications are less frequent. On examination, the patients are usually severely ill with fever, rose spots, abdominal tenderness, and hepatosplenomegaly, with cervical lymphadenopathy, and we can find respiratory crepitation on auscultation, with other specific clinical features of cholecystitis, pancreatitis, which are parts of complication of the disease, along with seizures or even coma. Complications usually occur in the third or fourth week of illness, of which intestinal perforation or hemorrhage may even occur at the end of the second week. Other complication includes endocarditis, pericarditis, hepatic or splenic abscesses, and orchitis. Please note that a drop in temperature to normal or subnormal levels may be falsely reassuring in patients with intestinal hemorrhage. Other complication may involve any viscous or system because of the bacteremia present during the first week, of which, for example, bone and joint infection is common in children. Mortality rates in the developing countries may be as high as 10 to 30%, which is much higher than the mortality percentage in developed countries, maybe because of the delayed treatment or multi-drug resistant strains. Long-term carriers, which will persistently excrete the salmonella in stool or urine for more than 1 year, they will represent about 1 to 4% of the patient with Salmonella typhi. Usually they are associated with biliary abnormalities like schistosoma hematobium and may be associated with increased risk of developing cholangiocarcinoma. This table summarizes the complication of typhoid fever. Diagnosis in the first week is difficult because of the symptoms are those of a generalized infection without localization. Typically, there is leukopenia in the CBC test. The diagnosis can really established by blood culture. Of course, multiple cultures increases the yield. Stool cultures are often positive in the second and third weeks. And to mention, the Widal test, which is old, is not specific. Like any bacterial infection, therapy must be guided by sensitivity testing. Traditional used antibiotics include chloramphenicol, ampicillin, and cotrimoxazole. Nowadays, fluoroquinolones are considered the drug of choice, but again, resistance is common. And cephalosporins, ceftriaxone, and cefotaxime are considered alternatives, but again have a slight increased treatment failure rate. And again, we can consider azithromycin as an alternative when fluoroquinolones resistance is present, but are usually used for milder disease. Antibiotic should be continued for 2 weeks, and we have to expect a continuous fever up to 5 days after starting the antibiotic. And even with effective antibiotic, there is still danger of complications. Treatment of chronic carriers should be guided by antibiotic sensitivity testing, and sometimes cholecystectomy may be necessary. Prevention is mainly by improved sanitation and living conditions. And we have to know that there is 3 available typhoid vaccines, 2 of which are inactivated, injectable, and 1 is oral live attenuated organism. This is my thank you slide. Logic will get you from A to B, but imagination will take you everywhere. Albert Einstein.